All right, and we are live. This is Dr. Hockman. I'm a family medicine physician and founder of CEO of Happy Day Health, where I help doctors find incredible private practices to join and the occasional hospital-based practice too. And with me today, I have Dr. Gupta. You will not believe who I have here. Dr. Gupta started his own direct primary care practice in pediatrics. So he's here to spill the beans. Dr. Gupta holds nothing back, so let's see where we go today.
I wonder why you jumped to that. I hold nothing back. Is it because of prior interactions?
Well, of course, but it's what I love about you. So
Yeah. Yeah, I'm not one to sugarcoat things. So I guess.
exactly. Well, and so for everyone watching, what Dr. Gupta and I were talking about right before we went live, we have a little bit of differing opinions on how we deal with our fears. So I say, screw fear, do it anyway. And Dr. Gupta, why did you tell us your thoughts?
No. I mean, you have a very valid argument there. And that's true. I mean, sometimes you just have to jump off the deep end, and sometimes you do have to, it's sink or swim, right? But I think also, if you're looking about going into the DPC or concierge or hybrid kind of, you're looking into an alternative payment model. Let's be clear. It's not a different type of medicine. It's a different type of payment model. If you're, I think it's very valid to be afraid if you have no idea what you're doing. Many people are afraid of the unknown. So don't jump in if you have zero clue what you're doing. If you have like zero business sense and you're unwilling to learn about how to, start up a simple business, because this is actually a very simple business. It's far simpler than the traditional insurance-based model. But if you haven't done your homework, I wouldn't jump in. So that it's very valid, those fears. But as you learn, as you meet other doctors who have done this, a lot of us are very willing to help you out and kind of ease those fears. But you have to be open to learning something that's different from the status quo.
Yeah. Open to
All
learning,
too
open
often I
to
hear too many doctors saying like, well, I never learned this in medical school. Well, like, when the hell did that stop you from learning anything? Like, medical school is not the end all be all. Like, you're the top of your class in high school and then in college and then somewhere in med school, but you graduate. But like, you can't just be like, I never learned this. Like,
go learn it.
we
Exactly.
know how to learn. We're doctors. So
That's funny. I was speaking with a med student this morning and she said, well, she's a first year med student. She said, what one piece of advice would you give me at this stage? And I said, learn business. What else? What could
yeah,
be better, right?
learn business. Learn, understand what economics means. Understand how to forecast kind of where the economics are going, and actually and actually learning how to forecast actually is very good for business, your practice too, because you will actually be able to meet the needs of your patients. But yeah, keep learning.
Yeah, never stop.
It's almost for many doctors, I think they're comfortable in kind of maintaining the status quo, and that's exactly what's broken with the system right now.
Yeah, exactly. Well, you are not okay with the status quo. So let's talk about your DPC and tell me a little bit about, for you, what was it about leaving where you were, starting a direct primary care? Tell me a little bit about that.
I think, this interview is probably coming at a time, I don't know, maybe it's in the stars or something, but I just 10 minutes ago, I just came back from a funeral of a patient of mine who was born with a very rare genetic disorder. Multiple specialists were involved. And we had probably about, it's a very rare disease, only 4 currently living, well, 3 now currently living on the planet. But from case reports, the average lifespan was about 16 to 20 years. He passed away last week. But he came into my life about 6 years ago. At that time, I was working for an insurance-based practice, and I had just started there, and so I still needed patients, and so I didn't exactly have all the time I needed to go through his like 17-inch kind of medical records, but I was able to kind of dig through his records and did the best I could. As I became more popular at that practice, within probably a year, I was seeing 40 patients a day.
Whoa.
So 40 patients a day, that is the status quo. Here we are. We're here in New York, where pediatric reimbursements are based off of New York Medicaid. And so I think also pediatricians need to understand that pediatric salaries are very regional, very, very state-based. Pediatric salaries are based off of those state Medicaids. New York has a fixed Medicaid pool, but we have a very large population, so it gets divvied up. So seeing 30 plus patients a day is pretty much the norm here in New York. Now you can't, I guess for for some of the run of the mill, like kind of your upper respiratory tract infections and strep throats, I guess that may be okay. But unfortunately, you have chronic kids with chronic illnesses, rare disorders, who are left in the cracks. They're looked over. They're passed over, and it's just refer. So by the time I quit my job over there by 2 years at my 2-year mark, and it was a lot of it had to do with this patient. Knowing him and others who were medically complicated, I couldn't be the doctor that they needed. And I knew that the system wouldn't allow me to be the doctor that they needed. So that's how I started this. Call it direct primary care, call it concierge. I don't care. I mean, whatever. It basically, I practice medicine, and that's what we should be calling it. That's how it was done. That's how it's done everywhere else. But the only reason why, I get a label of DPC or concierge is just because of it's an easier way for people to understand that I don't take insurance. And but there's a reason. I've been involved with this kid's family, for most of his life. And he was one of my COVID casualties. Actually, he's my only COVID casualty. He was in the hospital for 8 months. Oh. And so, but he was in the hospital, and I was still the point person. I was still the quarterback. And that's something that's very rare. A primary care physician still running the show. And I was. The specialists at the hospital were doing their thing. And they just focused on their body part, their organ. But due to mom's insistence, every piece of documentation and every lab result was being directly sent to me. And somewhere in the summer, he took a turn, and he was intubated, and he was in the ICU. He did come out after, gallons of antibiotics, and but they started talking about a trach. And I'm getting all the reports. I mean, I could see he was entering into organ failure. His heart's given out, his kidneys functions, but the nephrologists are focusing on their thing. The cardiologists are focusing on their thing, and nobody stopped and said, wait, let's bring him home. So I actually had to drive into the city to call a meeting. And I discussed this with the parents beforehand and said, listen, his organs are failing. He's going to die there. We need to bring him home. And so we set up that meeting where I could be there with the specialist. And I said, look, I mean, you guys can keep his heart beating, but but that's not life. Let's give this kid whatever childhood he has. So he did go home and he did go trick-or-treating. And so that's, I think, probably my greatest accomplishment. He went trick-or-treating and he just passed away last week.
Oh.
But it's an honor. It's an honor that the family trusted me. It's an honor that I was able to have that talk with them to bring their little boy home. But that's medicine.
That's beautiful. That's
And
why we went into primary care.
yeah, but what I was, when I was first his doctor and seeing 30 patients a day, I would have punted him. And that would have been, he would have just died at a hospital. And, nobody would have taken charge of that. So he died last week with all of his cousins and his aunts and his uncles and his puppy in his lap. And so it was, and they had actually called me. They had called me that night, and somehow I slept through it. I have no idea. I don't sleep at all. I slept through their phone call.
Oh.
But the parents said, that's okay. Q, that was my patient. Q probably told whoever the power to be that I needed to sleep. So it's all right. Because he's kept me up many nights.
Well, it's interesting because as a physician who's been in, a higher volume practice, the thought of that is mind-boggling. Like, oh my goodness, how did you have time to go through the charts and get to know the family and drive down to the hospital? And so that's really a striking difference.
What I've created.
Yeah.
I'm the pediatrician that he deserves. He needed. And so this was, it was a beautiful, he had his wake yesterday and the family asked me to speak.
Oh.
And so, and then today the burial, the ceremony was for family only, but I was part of that family. So it's tough.
That's so beautiful. I just find the dying process is one of the most profound parts of a patient's life. And it's really important to be a part of that.
We don't allow our, at least in this country, I don't think we give the honor. We don't give an honorable death. We do everything we can. We poke and prod, do surgeries. We try to keep that heart beating, but there's not a doctor who will stop and say, what are we doing? Stop. Let's go home.
Yeah, for sure. And I think that
at least, and definitely not in pediatrics.
Yeah, no, that's a tough one. Wow, they were so lucky to have you.
Yeah,
And you're lucky to be able to do what you do and to have that courage and, to go out and start your DPC and be able to give them the care you want. And what's best for the patient is best for the physician too. I mean, let me ask you this. How burnt out are you? I mean, you put your soul into this patient. You are doing work after hours. How burnt out are you right now?
Not as burnt out as the previous 5 jobs I had. I would work in all these jobs, bust my butt, burn out every 2 years, and keep switching jobs. So no, there is fatigue and exhaustion, and COVID definitely brought a lot of that. But I have to count my blessings that because of COVID, I became more relevant. Like while other practices were pretty much shutting down and doing telehealth or trying to fumble with telehealth, they restricted their access to their patients and just kind of like punting their patients off to an urgent care, which is rejecting them because they can't handle the volume or go into an ER. For me, I was able to, okay, well, listen, my medical office building might not be the best place for your child. Okay, I'll come to your house. Did a lot of house calls. I did everything safe to try to keep my patients from getting infected. Did house calls in their front porch, backyards. We'd set up a tent and do it in my driveway, in my parking lot. But the kids got their vaccines. None of my patients ever fell behind. And also, I think also another thing is, I don't know how this is in the rest of the country, but man, the pediatricians here in New York State have done a piss poor job of giving COVID vaccines.
Wow.
Just a completely shitty job. They just should not call themselves pediatricians. I mean, it's a
We're live.
fucking
Can we
job.
not say
Oh,
any
sorry.
cuss words?
Oh, sorry. Sorry. Listen, but I think I am allowed to call out my colleagues who did not step up to the plate to protect their children. We were always the first to administer the COVID vaccines, and we did thousands
Just in your practice?
yeah, in my practice. But we didn't just vaccinate only our patients. We vaccinated the community because of the incompetence of the other pediatricians. Now somebody's going to say, like, wait, we're not incompetent. No, it's true. You're a very good pediatrician, but you work for a crappy system.
Yeah. And it really doesn't allow us
I think
to
I get some kudos
medicine
right
that we
there
need.
for saying crappy and not what I wanted to say.
The S word. Thank you.
Yeah, so crappy. But yeah, they're working for crappy systems where they have zero leadership. Now, I would argue, well, like, fight for your damn leadership. Kudos. See, I didn't use the word I wanted to use. Fight for your leadership. But I think maybe a lot of pediatricians, or also just physicians in general, have probably been just conditioned to just roll over and take it.
Yeah. And there's actually, that's a good point. We have a question that someone asked right now is, what resources did you utilize to help start your DPC? And before you answer that, I will tell you that this is something that I'm starting to do. So for anyone that's watching this and is interested, I can absolutely help you start your direct primary care practice. But for Dr. Gupta, what did you use?
I think the first thing I did was actually. Here's the weird thing. The resources I used, honestly, I was at New York Sports Club working out in January, and I saw how full it was with people, and I was like, my God, everybody's gonna be, this place is gonna thin out by March, but they're still gonna keep paying their monthly membership. So I actually realized about the subscription model right then and there, because I'd been using that with Netflix, Netflix, my New York Sports Club. I actually didn't discover DPC until about maybe about 2 weeks before I opened.
Wow.
So once I opened, once I discovered it, it was great. It was great because I found a dpcfrontier.com, and that was the information I needed. So I got everything I needed from there, and then I reached out to other doctors. Of course, like, I think everybody who's entering this world, I contacted the Umber brothers in Kansas. And then I ended up using their EHR system. But really, the reason why I was actually planning this, I didn't have that label DPC until about 2 weeks earlier. And then I actually eventually dropped that label. But I had already had this business plan because I'm looking at subscription models like your sports membership, your sports club membership, Netflix, but also knowing the overhead costs of running a traditional medical practice. Now, the overhead cost was ridiculous. It's ridiculous. I don't know why. I mean, I don't know why we think this is right. It's terrible. Yeah, you got to hire an army of billers, an army of secretaries, an army of MAs. It's all about volume. Well, you got to pay those people. Now, if you're getting paid $32 for 99213, but you got to pay all those salaries, you're going bankrupt. And sure enough, that's what's happening. So we have the current consolidation of practices. If you're an independent practice, you're getting squeezed out. The big hospital systems are basically muscling the insurance companies into giving them hospital-based reimbursements, but the independent physicians lower and lower reimbursements for the hopes that, well, they're going to get absorbed. They're not going to get bought out. It's not, we shouldn't call it a buyout. There's no exchange of money. No, you're getting absorbed. You're getting absorbed so you don't have to pay, you don't have to declare bankruptcy. That's it. And that's the state of things in New York. And I'm not going to assume that that's the same way in other states, but in New York, that's what's happening. But if you take a look at what the overhead costs are and what is the cost of actually providing medicine. So what's my cost? What's the cost of me plus my rent plus any ancillary, and compare that to the overhead costs of running a traditional practice, it was about a third. It was about a third, but that's a bare bones traditional medical practice. Now it's actually compared to like the practice I left, where it was a very established practice, it was about 10% of their costs.
Wow, that's crazy.
So, these medical practices that are taking insurance, you got to look at the margins. The margins are so thin that they have to make up for it in volume. Well, why not have a wide margin and take less volume? It's that simple.
Business is math. You either have to charge a tiny little bit, but then see a ton of people, or charge a reasonable amount without insurance and see a reasonable amount of patients.
Yeah.
Yeah. So one of the things that I hear a lot of physicians, their hesitation in starting a direct primary care or even joining a direct primary care is about the pay cut. Tell me a little bit about your thoughts on that.
Okay. So starting my practice, yes, there was a pay cut. I mean, but that's why but I think any entrepreneur needs to save up some money before venturing off into their own business. And it will take time to recoup your losses. So for me, my wife and I, we had been very successful in some investments and then paid off my student loans. And then we thought, okay, what's our next investment? Well, let's invest in me. So it took about for me, realistically, maybe about a year and a half to break even. And then I think after my second year, I was able to start paying myself. My third year, I surpassed my any income I ever had. And now, yay. No, we're very comfortable now.
So now you get it. Now you get it back. You're getting all that investment
back. So now
back.
the pay cut. Okay, so now hiring somebody. This is how you and I met. I went through many different ideas of how I'm going to hire another pediatrician. So one thing was, when I was hiring somebody, I realized what I wanted initially, maybe about 2 years ago, was I need somebody who's going to be a go-getter just like me. Somebody who's going to be hungry and who's going to hustle. So I figured, let me give them let me maybe start them off with a lower salary and then give them bonuses as their increase their salary as more and more patients join. Turns out a lot of pediatricians just don't get it.
That is my experience. Yes.
It's like, they just don't get it. Bright people just can't figure simple math out. But okay. It's actually a model based on, so I'm in New York, right? So that model is based off of Wall Street. That's how they pay their people. But too complicated for the smartest kid in high school. So, okay, fine. Maybe people didn't want to take a pay cut. So then I started to realize, okay, maybe I just need a straight up employee. Someone just fine. And turned out one of my good friends who worked for a traditional practice a mile away. She's like, I called her one day. I was like, hey, do you know anybody who wants to, looking for a career change? I desperately need a pediatrician. And she's like, well, what about me? I was like, oh, wait, I thought you were happy over there. She's like, I am happy, but I can't keep seeing 35 kids a day. Oh, oh, so Now she's an experienced pediatrician. She's involved in the community. She lives locally. So I said, okay, I'm going to offer you this much. And she said, well, I make more than that. I was like, oh, fine. I'll pay you more. Come on over. And now she didn't get a pay cut. She got a pay raise and now a better lifestyle. So there you go.
You're the exception, not the rule. I'll tell you that.
Okay, well, let's talk about it. So, let's talk about the DPC. All right, if you're talking about other DPC practices, this is still in its infancy, right? So people are they were probably like me, looking for somebody who had the same hustle. I had to learn the hard way that no, only one guy is going to have that hustle and that. We're the diamonds in the rough, right? Nobody's going to have that hustle. So maybe so I guess you're hearing that other people are kind of offering like a base pay and then give them increase their salary as they go along, or if they're looking for an employee.
So, well, of course, like I always say, you've seen one DPC, you've seen one DPC.
Yeah.
It varies, but yeah, most of the time it's like you're saying the Wall Street thing where you start lowering, go higher, and the potential earning is significantly higher in DPC.
Yeah.
Significantly.
Like I'm making way more.
Yeah.
It's great.
Yeah. And you're seeing, 10% of the patients?
I didn't see any patients today because I went to a funeral.
Yeah.
But I was able to go to that funeral.
So yeah, what the physicians typically look at is starting salary, and that's where,
like where does common sense go in us physicians?
I understand the logic behind it. We put 11, 12, 13 years into studying.
Where did it go? Anyway, so my friend, here's the thing. She's not going to get that income potential because I'm front loading her. I'm taking a loss for the next year at this rate. Yeah. But so actually she started about 3 months ago. We've already had a 15% growth.
That's amazing.
In earnings.
Congratulations.
So I estimate probably about a year. I'm taking that hit on her salary. But the thing is she's getting paid more. She's got a flat salary. That's it. And that's what she's comfortable with. And that's okay. She's getting paid more than what she was. She's got a better lifestyle now. She's got way more job satisfaction. And she's getting paid well, but she's going to be capped.
Yeah.
She might, I hope to give her maybe a 3% increase every year because why not? Say if I started her off on like a base salary similar to Wall Street, like the iBankers, and then gave her a bonus, there's way more potential there. Especially if it's in less than 3 months, we already have a 15% growth in earnings. And and now I just put us on a wait list again.
Wow.
Yeah, because I'm going on a African safari for 2 weeks. So I was like, I don't want to burn you out. So we're not taking any more new patients until I come back.
That's amazing.
So you just take care. But, could we, we're going into December, could we have already, could we be approaching like 30% growth by then? We could, but so, I mean, we're doing well. But, could she have been looking at, maybe not next year, maybe she would have matched what she left, but maybe the year after she could be getting way more possibly. Mm-hmm. But I gave her both options. So some people I think a lot of physicians are comfortable with the certainty of having that flat salary. That's okay. But I think also many physicians are comfortable, I think, in their current jobs, or they're choosing to say they're comfortable. They like, especially I hear a lot of pediatricians say, I really like my patients. Okay.
But that's not the job. I know.
But I really like my I really like what I'm doing, but I'm really burnt out and I have no time for myself and I'm not paying the bills.
Yeah.
Okay. You can do what I do and still like your patients.
Yeah, I know. I love my patients, especially when
Yeah.
I have the time to get to know them.
I've gone on vacation. We've gone on vacation with our patients.
Wow.
Yeah. We've done 4 trips with our patients, with different families. Yeah.
Wow, that's pretty cool. That's like the
Because,
true community doc.
yeah. Yeah. I mean,
That's
that was the point. That was cool. But yeah, well, that's what I envisioned for myself,
that's great.
and so, I like my patients. I'm a part of this community. I vaccinate this community. I do everything I can. I do everything I can to protect my community because I know that the big hospital systems aren't. Let's just be frank.
And I'll say to everyone watching that doesn't know Dr. Gupta, you decided what you wanted your practice to look like and you went out and did it. There's no one telling you you need to see this many patients, you can't, you
No,
have to take the following patients, you can't take the following patients. You
no,
just
no.
said, this is what I want to do. And I mean, there is so much more that we won't go into that you've done that
We have the
I
strict. We have the strict no asshole rule.
no asshole.
Yeah, we have to. We
And you can
interview
do
our.
that because it's your own practice.
Because I don't have an insurance panel telling me what I have to do. Like, there's so many patients I had to see that I didn't like. I'm not the patient. The kids are fine. It's the parents, right? I don't want to see them. I hate them. They're terrible people, right? Like, so we interview all of our families before they join the practice. Now it's me and Dr. Gallagher interviewing, so they get to meet both of us. And it really comes down to after doing this for over a decade, almost 2 decades now. Oh my God! Oh yeah, I'm getting old. I think I can read people and kind of and basically it really does come down to, like, no asshole rule. If you're an asshole, I can detect it. I could smell it. You're out. And that happens. It's like, thank you very much. If your interview lasts like 5 minutes, you're not in. If your interview lasted 45 minutes, you're definitely in the practice. So, but also we do take references from other who are patients of the practice. We evaluate whether, also we will evaluate whether they need us or not, right? So sometimes we might be on a wait list. I do that, wait list in air quotes. But if I got a kid who, just like comes to our door, comes to us, just like my buddy Q, of course I'm going to take him. After, so Q's he was in hospice. And just a couple weeks earlier, we took on another patient who's going to be in hospice in the near future too. And that's, these families weren't looking for us to cure their kids. We can't cure the impossible, but I think they just needed somebody on their side. And it's going to be hard. I mean, we're at some point this kid's going to be in hospice. And it's going to be another difficult one, but we have the honor of being that doc, that trusted doc. Yeah.
Yeah, I love that you do that.
Yeah.
We had a couple questions. One is, are medical schools or residencies teaching us about business? Not that I know of. If they are, I hope that someone can respond to your question.
No.
I've never
No,
heard of
listen. Medical school and then residency is going to be boot camp, right? It's going to train you into submission, into what the status quo is.
Yeah, I think that unfortunately it takes a lot of self-direction to teach ourselves business, and we can. I mean, we're
very
people,
capable,
so we can do it.
We're capable. I mean,
yeah. And then someone asked about adding ancillary revenue stream to increase income. And I think this is something that is so important in the insurance-based model, where you absolutely have to add, other vertical streams of income, like, remote patient monitoring or other things that can be good for your patients, or, allergy treatment or whatever that may be.
Being accessible to your patient when they need you is the best thing for your patient.
Yeah.
some of these, like, yeah, I give my kid, I have 4 kids right now who are getting allergy shots. I don't charge them more. That's just part of their monthly fee. That's too much nickel and diming if I did that. That's no. It's I'm accessible. That's
Yeah.
what they need.
Yeah.
Additional revenue streams. I know maybe some practices like do, like, I guess, laser hair removal or like ear piercings. No, I don't do that.
Yeah.
We did have an additional stream of revenue during the height of, during COVID testing, though. It was something originally I only offered COVID testing for my members of the practice. Then I ended up, like, then the demands on COVID, the test results were becoming like, then we started getting test results like 3 days, 5 days. I was like, no, that's not good enough for my patients. Like, I need to know now. Like, I'm their doctor. I need to know. Like, am I isolating little Billy into a room? I need to know now. So I ended up buying my own PCR machines, and then, but it was very expensive. So that was the one thing that I had to charge in addition to my membership fee, was the cost price of those 30-minute PCRs. But I charged the cost price. And then I eventually found a boutique lab that was able to give me the PCR results the next day. So we partnered with them. And so my patients, if they didn't want to pay like the cost price for the rapid PCR, at least I'll get them back the next day. Then word got out that, like, oh my God, your pediatrician's so awesome. He's done this for you. And I'm like, oh, I'm just doing my job because, so then I started charging the community, and they would charge significantly. I would charge them significantly more, but I give them a super bill. They can get reimbursed for their PCR tests and stuff like that. But we definitely had a very good revenue from that. But now, as the demands for testing, that kind of alternate revenue stream was not who I am. I'm a pediatrician. I want to see patients. That's all I want to do. I don't want to sit there and nickel and dime and do this and all that. But it was good. It was good. I was able to do what I needed to do for my community. Like some of the non-members, they're paying, $200 for these rapid PCRs. But then we'd get a call from the food pantry. We had a little outbreak from some of the kids there. So, that $200 would pay for the, my little guys at the food pantry. It was a little Robin Hood type thing going on. But that wasn't, but as that started to diminish, thankfully, I used all that money that we had made, and I started putting that into, like, okay, now let me find the next pediatrician. So
good for you.
So,
well, thank you so much. This was very helpful.
Oh.
Any last words with our last 2 minutes before we go? Anything to tell doctors who are considering direct primary care?
I'd say figure out who you are. What kind of doctor you want to be. Are you that doctor right now? If you think that you're going to if you're not that doctor right now, but and you're thinking, I'm going to quit my job and hop into another traditional status quo job, you're never going to be that doctor that you're meant to be. DPC or concierge, it's not a different type of medicine. It's medicine. It's an alternate payment model. You can be the doctor you want to be if you do this. You make your rules. And you can make more money, have a better lifestyle, but you are an entrepreneur, and it will be hard work in the beginning. So.
Yeah. Awesome. Thank you. Well, if anyone's watching this and wants help starting their DPC, please do reach out to me. Or if you are looking for a practice to join, whether it's a direct primary care or a regular, you can message me on LinkedIn or on my website, which is www.happydayhealth.co.
And I apologize for the colorful words.
It's fine.
All right.